Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Mona, 45 years, presented with collapse. Please take history, examine her, and address her concerns. You
Okay.
ready, Dr. Minas?
Hello,
Hello,
Okay, here you
doctor.
go.
I am a Dr. Mahmoud, one of the medical doctor today. Am I talking to Mrs. Mona, 45 years old?
Yes, doctor.
Nice to meet you.
Nice to meet you.
Mrs. Mona, I have been asked to talk to you as well as to examine you and address your concern. Is that okay?
Okay, doctor.
Thank you. Now, Mrs. Mona, can you tell me what's troubling you?
Yes, doctor. Actually, I have collapsed, doctor, since morning today.
Okay. Mrs. Mona, what do you mean by collapse?
Yes, doctor. Actually, yes. I assume to be loss of consciousness, doctor.
Okay, I'm sorry for that. And how you feel now?
Yes, now I'm okay.
Okay. Is it first time?
No, doctor. Not actually. Not first time. It happened for me before, doctor, many times.
Uh, over how long this occur? For how long?
Yes. Just for a while. I think a minute.
Okay. And as you said that this occur before. When that when do you remember what that happened exactly?
Yes.
Exactly.
Yes, this attack, yes, doctor, it started for me before 6 months ago.
Yes. And you said that you lost consciousness.
Yes.
Yeah. And that time recovered spontaneously or after take any medicine?
Yes, doctor, yeah, not recovered spontaneously. Actually, I took some medication through the
Do you know
needle.
that? What? Sorry.
Some medication, doctor.
Do you know
Yeah.
that what is medicine?
No,
Okay. And do you know that what your diagnosis that time?
no, doctor.
Okay. And any jerky movement with this attack when happened?
Yeah, sometimes.
Yeah. And as you
During this
said that
attack
take
today, yes, there is a jerking,
today.
shakiness of my body, yeah.
And that first attack before 6 months, same like this attack or different?
I think similar, doctor.
Yeah. So you lost your consciousness and you have jerk movement in all of your body or in a specific part.
Yes, in all of my body.
Yeah. And sorry to ask you that do you lose your control of your water work
No,
or
not like
waking?
that, no. No.
Okay. Okay. And also, I want to ask you that before that you feel in collapse, what do you do that time? What are you doing
Yeah,
that
yes.
time?
I'm preparing for the breakfast this since morning, yeah.
Yeah. Any feeling of dizzy when you standing from sitting, when you stand up from sitting position?
No, doctor.
Okay. That time, do you check your blood pressure, blood sugar?
I think yes, my husband yeah, he check it and find it low.
Okay. And anything make it better, like for this attack, like take sugar like that?
Yes, yes. My husband, he give me,
Okay. Any hand shaking, hand sweating?
before this attack. Yes.
Okay. Mrs. Muna, do you have any history of high blood sugar?
No.
Okay. Do you have any weight gain?
Yes, doctor. Actually, recently, and I'm not exact. My weight is become increased.
Yes. So there is increase in weight, but you did not know how much exactly.
Yes, I didn't measure it.
And there is increase in appetite.
No,
Okay.
my appetite
Uh,
normal.
okay. Uh, any weakness in your body?
No, doctor.
Any headache?
No.
Any mouse deviation?
No.
Any visual problem?
No.
Any abnormal sensation?
No.
Any abnormal gait?
No.
Okay. Mrs. Mona, do you have any, you said that there is any intolerance for hot
No,
weather
doctor.
or cold? Abnormal intolerance?
No.
Okay. Uh, and what about your period?
Yes. My period is fine.
Okay. Do you are you pregnant?
No.
Okay. And now I want to ask you some questions.
Mm-hmm.
That do you have any history of hospital admission before?
Just before one attack, doctor, because of this attack.
Okay. Any history of blood transfusion?
No.
Any history of high blood pressure?
No, doctor.
Any history of nasty growth?
No.
Any history of gland disease?
No.
Okay. Any history of surgery before?
Yeah, no.
Okay. Can you show me your medicine list?
I didn't took any medicine, doctor.
Okay. And do you have allergy for any known drugs?
No.
Okay. Mrs. Muna, I want to ask you some private question.
Okay.
Do you have or do you take illicit drug?
No.
Okay. Mrs. Muna, what do you do for living?
I'm housewife, doctor.
Yeah. Uh, what about financially? Are you support?
Yes, I'm fine.
Okay. And how these symptoms affected your life?
Yes, just when this attack, doctor, yeah, it affect me.
Okay. Mrs. Muna, do you drive?
No, doctor.
Yeah. Now I want to examine you.
Yes, you can.
Yeah.
What do you want to
First,
examine?
I want to see general look, general observation.
Okay.
Any
The patient look obese or overweight.
where
Mm-hmm.
overweight.
Yes.
Okay. Start from hand, looking for look for any
Mm-hmm.
first for clubbing, and look for any
No
skin
clubbing.
changes
Like what?
like hyperpigmentation.
Okay, negative.
Okay, then pulse.
Okay, normal.
Okay, then I would like to examine eye for pallor and jaundice.
Okay, the patient not pallor, not jaundice.
I want to examine the mouth for any sores,
Negative.
any gingival hyperplasia,
Negative.
hygiene. Then neck. I want to examine neck for any thyroid enlargement,
Negative. No need,
any
doctor.
any lymph nodes.
No.
Also, I want to examine then I will start to examine the abdomen.
Okay, for what?
Abdomen for any organomegaly.
Mm-hmm. No organomegaly.
Okay, and I want to also examine the skin for any skin changes.
Okay. No skin change.
Yeah. Uh,
Mm.
okay, I want also to do finger prick for blood sugar.
Okay. No, negative.
Okay. Now I want to examine. I want to ask you some questions.
Mm-hmm.
Any frothy urine?
No.
Any change in water walk,
Like what, doctor?
like in amount or
No.
color? Okay. Any pain? Pain when passing urine?
No.
Okay. Any shortness of breath or breathing difficulty?
No.
Any awareness of heartbeat?
2 minutes left.
No.
Okay. Any joint pain?
No.
Any skin change?
No.
Okay, Mrs. Muna, now do you have any concern?
Yes, doctor. What I have, doctor? Why this attack it come for me, doctor?
Yeah. Mrs. Muna, after talk to you and examine you, I believe that we have many possibility, but
Mm-hmm.
one of them that you have a condition called hypoglycemia. This condition in which that medical condition in which there is low blood sugar in that cause symptoms that you have, and most likely that because you have maybe you have some tumor or some abnormal growth in your gland in your tummy named pancreas,
Mm-hmm.
and we need and we need to exclude that. We need to admit you, and we need to run some blood test and some some blood tests and imaging, and we will manage you in a team of many specialties that contain medical doctor, gland doctor, specialized nurse, and may will need to involve also this surgical doctor. And then after that, accordingly, we will give you the plan of management according to our result of blood test and imaging. Any other
Okay.
concern?
No, thank you.
Okay, time is up. The examiner question.
Yes, present your case, Doctora.
Yes, this is Mrs. Mona, 45 years old, presented complaint of recurrent attack of collapse or loss of consciousness, and that loss of consciousness that preceding by symptoms of hand shaking and hand sweating, and that take and then that time of collapse had low blood sugar level, and relief by take sweets. Yeah. On examination, no specific finding apart from being overweight.
Okay, what is your diagnosis and differential diagnosis, doctor?
My diagnosis hypoglycemia caused due to glucagonoma, my first, and other may be hypoglycemia caused by as a side effect of hypoglycemic agent, but patient she did not mention that, or maybe a part of other endocrinology or other endocrinological disease like men.
Okay, so why men can cause hypoglycemia?
Cause maybe cause pancreatic tumor at the part of men.
What is the name?
Glucagonoma.
You mean glucagonoma or insulinoma, doctor?
Sorry, insulinoma. Sorry.
Mm.
I mean insulinoma, yes.
Yes. Okay, anything else?
Other differential. Yeah, men or insulinoma, isolated insulinoma or men.
Did you ask the patient regarding the men? To exclude the men?
Actually, I came back for systemic review, but no time that I ask. I want to targeted question, but that time, خلاص, already time finish.
Okay, sir, what is your workup for this patient and plan of management?
Okay, first we need to admit patient, and we need to do for her that blood test. Started with basic blood test, full blood count, liver function test, urea and electrolyte, and renal function test, and inflammatory marker. Specific, we will need to do what? Specific, we need to do for her that insulin level, and we need to do for her also الانسولين level والC peptide level, and we need to do calcium and imaging of the abdomen, and may need genetic test also.
What kind of imaging?
CT. CT scan of abdomen. Uh,
Okay.
okay.
Anything else? Any test
Yeah.
specific for insulinoma, doctor?
C peptide.
Okay, so what is your treatment, doctor?
Treatment of insulinoma. We will give her medicine. Dioxide.
Okay.
Yeah.
This is the first option for treatment.
Mm,
Mm-hmm. Okay, anything else?
no, thank you.
Okay, thank you, Dr. Minas.
You are welcome.
Okay. Thank you, Dr. Minas. Dr. Sarah will comment, then I will comment.
Uh, yes, Dr. Minas, actually it did well, but I think regarding your history, you're slowly talking, and also your history not organized. So if you, that is why you didn't involve all of the scheme of the history. Okay, you did analyze the collapse perfect, but yeah, when you are find this patient, she has hypoglycemia, and already you are asking regarding the weight. Yeah. So at this time you think regarding insulinoma. Am I right? You get, I
Yes,
think,
yes,
your
that time.
diagnosis. Yeah. What?
Yes, that time I thinking of insulinoma with weight, so I ask you weight gain.
Yes, yes. So yeah, you get your diagnosis, but so we need to ask regarding the differential and the cause and other. The insulinoma, it could be alone, it could be at the part of the main. So in your case, at the part of the main, when we need to ask regarding the symptom of hypercalcemia as a part of hyperparathyroidism, and also gastrinoma, like the heart pain, and also other parts like prolactinoma, acromegaly. Okay, prolactinoma. I'm sorry for asking these special questions. Any milk discharge from your breast? Acromegaly. Do you have any frequent change in the size of your the hand or ring size, feet size? Any change in the facial appearance? It's most important to ask regarding this. Also, you are asking me regarding the diabetes. Diabetes, you are excluding this hypoglycemic attack in non-diabetic patient. And also, we need to ask regarding the Addison. Yes, you are asking me, do you have any dizziness when you are changing your position from sitting to standing, and tanning the skin? Okay, so in examination, just the aim of the examination to confirm this, just we need to do blood sugar testing, and we need to check the blood pressure sitting and standing. We need to search for the association of the men, okay, from the hand, if there's any, the size of the hand, any hyperpigmentation in the palmar okay, to check the proximal myopathy, for the eye also, Beller jaundice. Okay, the face of the patient, if there's any change in the facial appearance, Broganism, prominent supraorbital ridge, the tongue, the buccal hyperpigmentation. Okay, in the neck, just the scar, not thyroid, the scar for parathyroidectomy scar, because this patient, it might have primary hyperparathyroidism and treat it as surgery. Okay, the abdomen is the most important in examination. Your differential, yes, the first insulinoma in this patient at the part of the main, or insulinoma alone. Okay, Addison disease. You can keep it also in your differential. Okay. So the investigation, apart from basic investigation, the most important investigation to or specific investigation to confirm your diagnosis, you need to do prolonged fasting test, 22 hours. When you are admit the patient to do this test, you need to check the blood sugar, and you need when you are find it less than 3, we need to check the insulin, pro insulin C peptide as you mentioned. Okay. CT abdomen, yes, you are right. Other also we need to do pituitary hormone profile. Okay. And other parathyroid hormone, calcium, phosphate, magnesium, vitamin D also as a part of parathyroid hormone level also. The main treatment is the surgery. Okay. Partial pancreatectomy. If the patient not fit for surgery, you can give medications like dialogues, yes, dialogues, okay, diloxoxide and octreotide. Okay.
Okay.
That this all of your scenario. Thank you, Dr. Mina.
Okay, thank you,
Okay,
Dr.
thank
Sarah.
you, Dr. Yeah,
Well done,
thank
Dr.
you.
Minas. As a first practice with me, it's good. You reach diagnosis, you give good differential. However, you didn't pick up the finding of the association as main one is suspected in this scenario. Dr. Minas, please prepare the case for Dr. Sarah until I finish my comment, okay?
Okay, yes.
If you finish, just post it in the chat box. Okay, regarding the performance, the family history, she asked.
No, no.
Oh, no, I forgot.
Okay, so that's why you spend a lot of time analyzing the collapse and simply shortly try to finish it as soon as possible because you have a lot of questions to ask. Starting from the analysis, the best approach for the collapse at the approach of procedure in the communication before and during and after. So before, what you felt, what you were doing, any specific feeling, you felt, or you are doing activity, what was your position? Okay, all this question will help you. During, did you bite your tongue? Did you hit your head? Did you lose your conscious level? Did you have a change of the color of your face to yellow or to pale or to blue? Did you lose the control over your water work and the back passage? Next, after, did you wake up quickly? Did you take time? Did you regain your consciousness quickly? Did you have any headache after? Okay, you will have some of the clues. In this scenario, you got the clue, but you do spend a lot of time to analyze the other causes, which was different and far away from our diagnosis. Yes, you have to rule out seizure, but it's one only question you can finish. I think you finish the analysis of the complaint at the minute 5. Then after that, you start to ask about the constitutional, and you have here to ask about the past medical history, specifically about the diabetes. Are you having long-standing disease? No, doctor. Are you diagnosed with diabetes or high blood sugar or high blood pressure? Why? Because it might be as a part of the diabetes and the patient is taking medication and she might hide. The surgical history, the procedure, the allergy, you have to ask. You ask her about the admission. Any previous admission to the hospital? I think she told you there is previous admission. I'm not sure about this. Dr. Sarah, you mean to this admission or the previous admission with this attack? Anyway, let's go back to the approach. The good thing
Yeah,
also, Doctor. Sorry.
I think that time she meant that for previous attack.
Okay. Did you ask about what happened exactly? What's the diagnosis here?
I asked, yeah, what that time, what your diagnosis, and if
Okay.
recover spontaneously or take medicine. That said,
Yeah.
she did not know.
Okay. It's okay. So the previous attack is very important because it might go with epilepsy, for example. As I wrote in the chat box, always the age will give you sensible differential. In such age, 45 years, it will be different from the young age and it will be different from the more elderly patient. As we saw in this scenario, the most accepted differential will be insulinoma with hypoglycemia. It's not common in cases, but it comes. But what other possible differential? Either the patient will be diabetic on long-term insulin and he take or he took the insulin without a meal, or he do exercise, excessive exercise without eating. So it might be again as hypoglycemia. Or the epilepsy. Patient was already epileptic, although it's difficult because most of the epilepsy patient or epileptic patient will be younger and it would be improved on medication. Sometimes also it will resolve, but still you have to rule it out. Or cardiac. Definitely, cardiac cause is very important. The patient will feel palpitation or awareness of heartbeat, chest pain before or preceding this collapse, or arrhythmia, or as I said, awareness of heartbeat. So you can say this is cardiac by these symptoms, and it can be in this age, particularly those with dyslipidemic episodes. So they might have this issue. Apart from that, specifically, you have to roll out HOCM as written in the differential. HOCM in such age, you can ask specifically any family history of sudden heart attack. It's very important. Okay, if you have suspicious, of course, for a cardiac case. So if you have palpitation or awareness of heartbeat or chest pain, you have to ask this question specifically to rule out HOCM, and it might be your case. Don't forget. I'm talking about 45 years. HOCM, again, HOCM, hypoglycemia. Also, Addison could be, but it's also still coming in the young patient. However, it's not a rule because autoimmune can come in any age, or even Addison as TB or HIV, whatever, it might be the case. So it's not a rule to have the Addison as young only. Other than this, you might have long-term patient, long-term diabetes, uncontrolled, the hypertensive smoker, so he might be dyslipidemic. Now you are talking about stroke or TIA. So neurological history and examination should be done in this case to rule out TIA, particularly those patients with posterior circulation. Okay, dyslipidemia will be the cornerstone, atherosclerosis, stenosis, or even some patient will be cardiac AF, mitral stenosis complicated with AF, and he has or she has arrhythmia or the AF I mentioned. So thromboembolic condition might be the cause. Or it could be hypercoagulable state with, again, stroke or TIA. These are the most common in such age. Anemia, yes, could be the case. And some patient on medication or doing starvation or doing some diet regime, whatever. But in this age, as I said, these are the most sensible differential. Younger, you have to put epilepsy on the top, Addison, autoimmune, second differential. The men also could be here or there, although this age is much common as men, but the family history is crucial. You didn't ask about the family history, and you cannot roll out men. This is the only question can give you a clue either or to conclude this is men. If you didn't ask about the family history, you lost the clue of the case. Okay?
Yes,
Clear
okay.
now? Yeah. The elderly patient, definitely you have to put stroke or TIA in the top. Medication, polypharmacy, patient taking diuretics or taking vasodilator or taking beta blockers, heart or ischemic heart disease as a arrhythmia or heart attack, MI, you have to put it at the third differential. Secondary epilepsy to stroke, for example, could be the case. So it will be different. Pacemaker malposition or the function or the pacemaker is not functioning well. Pacemaker syndrome. If you have previous pacemaker insertion, really the collapse scenario is one of the wonderful, and you have to like and to love this scenario. Why? Because it's like a puzzle. You are collecting the puzzle parts, and at the end you will see the picture clear. Of course, you will have a clue to say this is the case of, for example, pacemaker syndrome. Depend on the previous past medical history or surgical and procedure history or ischemic heart disease patient with complete heart block. So if you lost one of these pieces, you will not have the complete picture of the puzzle. Is it clear now? The family history, the social you miss, Dr. Minas?
Social I did, but
You,
family history,
Family
yes.
history. Okay, always do them as a package. This is my favorite approach to ask the question as a package. Whenever you start to ask the constitutional, ask the whole constitutional symptoms. Whenever you start to ask systemic review, you have to finish the systemic review. Whenever you start analysis of the complaint, finish the analysis of the complaint. You have whenever you start to ask about the medical history or the past history, either medical or surgical or procedure or admission or allergy or over-counter medication, ask them together. The social and the HIV question, you can ask them with the family history as a package. If you do so, you will never forget any of this. Do you question as I prefer? Do you smoke? Do you drink alcohol? Do you drive? What's your job and what's the impact on your job? Don't ask about the financial support. The most important, the impact on the job and how you are coping with your daily activity. If she's not working, housewife, what the impact and how you are tolerating or you are coping with your daily activity. No, doctor, I have some problems, so we can refer or you can refer her to the assigned team who can help her in this regards. Otherwise, no need to ask about financial support. She's housewife. What the benefit of financial support? Okay, and if she's not financial support, what you will do? She has a family who's dependent on her or someone who caring about her or who's taking care of her. This is not our job. So our job, how she's doing and coping with daily activity. This is what she needs. Okay. The good thing here also you remember the driving, which is very important to stop until confirming the diagnosis. You don't know is it vasovagal, although it's not vasovagal, of course. Is it Addison? Is it anemia? Is it cardiac? And according to the code, after the the confirmation of the diagnosis, and if is it related to the driving or not, related to the position or not, after that the patient can drive. However, it was no, which is good. She's not driving, and you are lucky that she's not driving. Okay. Anyone or Dr. Minas, you want to ask any question?
No, doctor, thank you. Thank you to
Okay,
give me
Dr.
this
Sarah, you want
chance.
to ask any question?
No, just I'm waiting for scenario. Okay.
Okay, your
For
scenario,
radio, I think.
yeah, Mr.
Yeah,
John, 48
perfect.
years, presented with short of breath.
Mm-hmm.
Yeah, whenever you are mentioning as supervised, you have to say supervised for the confirmatory test of insulinoma.
Mm, yeah.
What was the test, Dr. Sarah, again? Sorry, I
The prolonged fast of 72 hours.
yeah, yeah, prolonged fasting test. You have to do supervised. It should be supervised because you
Yes,
might
yes,
admit the patient to
prolonged
do the
fasting.
test. Yeah. What the benefit of you are doing fasting or prolonged fasting test without supervising him or supervising
Yes,
her? The patient might go for hypoglycemia and she might die. So it should
Exactly.
be or supposed to be or it must be supervised.
And
Okay,
even we need to check the blood sugars when it comes below the less than 3. At that time, you can take a sample to check the insulin and proinsulin and C-peptide.
exactly. And it reached to 72 hours. Imagine patient might reach to this time to confirm the diagnosis. Other knowledge wise or knowledge part was perfect. So the investigation, the imaging, but again, the men, if you lost the case or if you lost the other component of men, you might lose the case. If this case is men, whenever you have a pancreatic cancer or pancreatic involvement, adenoma, you have to talk or to ask and to screen for men. They are not giving you a case of insulinoma only. They will give you a case with associated. So you have to screen for the parathyroid as well as pituitary. I don't think the pancreas might have two cancer in the same time or at the same time. You mentioned gastrinoma with insulinoma. I'm not sure it might happen or no, but I think you have to screen for the
For
others.
screening, yes, just for screening.
Yeah, if you ask difficult swallowing or acid brush or tummy pain, tummy distension, that's enough. But the most important, any feeling thirsty for parathyroid, any headache, any change of your mood, any bone pain. So this question for parathyroid adenoma and any headache or change of the facial features and change of the ring size or hand size and any discharge coming from the breast. This is for adenoma, pituitary adenoma. Okay, is it clear now for all? Yeah, so 72 hours supervised fast tests. Perfect. Okay. Yes, why Addison she have weight gain? I agree to say Addison as a differential. Why? Because Addison itself, as per se, Addison it can cause hypoglycemia. So we are still talking about endocrine cause. Yes, there is weight gain, but it's not necessary to be weight loss. So the Addison mean and insulinoma as a isolated insulinoma, this is the perfect differential for this case. Or if you have, by the way, it's very important to ask if this patient is taking insulin for any reason, maybe suicide or it comes before or it came before as it came as a suicidal attempt. So the patient is taking insulin by herself. You have to ask about the history of the family history. It might be conclusive for family history of diabetes, mother on insulin, and she has some social issue, and she tried to take the insulin for suicidal attempt. So she had this high insulin, and she has hypoglycemia. That time you can mention. Also in the female as a nurse, it came before as a scenario with patient taking sulfonylureas, and the patient also went to hypoglycemia because of sulfonylurea overdose. But it came as communication, to be honest, not as long. But what I mean, it's related to the case as hypoglycemia with the manifestation of hypoglycemia. Okay. Any question before moving to the next scenario? Dr. Sarah, I'm giving you some time to prepare yourself. Let's talk about the differential. Dr. Henry, the most sensible, really. He started with hypoglycemia, but I think he meant the hypoglycemia with diabetes, not insulinoma. But it came as first differential, which is stroke, TIA, epilepsy, vasovagal, HOCM, aortic stenosis. By the way, these are the causes of syncope in paces. It will be around these causes. Anemia also you can add, Dr. Henry. Anemia it comes as cause. Seizure, Dr. Ala, Dr. Ala, yes, seizure, TIA, vasovagal, cardiac, aortic stenosis, HOCM, long QT, Brugada, of course, with a family history. Hypoglycemia, Addison, perfect. Dr. Amarwa as well, cardiac, HOCM, arrhythmia, neurological fits, stroke, TIA, hypoglycemia, vasovagal, situational syncope. So it's still around the same possible causes. supervised 72 hours supervised fasting test. Okay, are you ready, Dr. Sarah?
Yes, Dr. Wasim, I'm ready.
Yes. Okay, here you go.
Okay,
Yes.
hello.
Hello.
I'm Dr. Auda Karim. I'm one of the doctor covering the service today. May I confirm that you are Mr. John, 48 years old?
Yes, doctor.
Mr. John, we are here to talk regarding your health condition. After that, I want to examine you. We can address your concern. Is that okay?
Okay, doctor.
So it came to my knowledge that you have been troubles with shortness of breath. Could you tell me more regarding that?
Yes, doctor. Actually, I have this breathing difficulty, and this actually happened before many years ago.
Mm-hmm. I'm
Yeah.
sorry for that. Okay. Did you seek any medical advice before?
Yes, I seek medical advice many times and give me medicine, but know that I have that too much benefit.
Any diagnosis given for you?
Many times it that may be this complication that I have some air or lung disease, some air in my lung, and that cause of this complication.
Okay. So now you have this shortness of breath. Is it started when it started exactly for you? Before many years, or it started?
Yeah, as I said to you, this is recurrent.
Mm-hmm.
Many years ago, I have this problem.
Okay. Now is it started for you sudden or gradual?
Gradually.
Mm-hmm. It happen all the time in the day, or it works in a specific time in the day?
Yeah, most of the time of the day, yeah.
Mm-hmm. Okay. So do you have any shortness of breath with while you with exertion or at rest?
Yes, even traced.
Mm-hmm.
Sometimes I have, yes.
Okay. Do you have any shortness of breath when you are lying flat?
No,
Any shortness of breath awake you from sleep searching for air?
no.
How much this shortness of breath impacting you?
Yes, doctor, this impacted me badly. I can't do my normal daily life activity.
Sorry for that. I will try to help you regarding this situation.
Yes,
Okay.
thank you.
So along
Thank
with
you.
this shortness of breath, do you have any chest pain?
Yes, doctor, sometimes.
Okay. Where is the site of your chest pain exactly?
That in all of my chest, not specific
Mm-hmm. Okay. May
side.
I know the nature of this chest pain? Does it look like aching or sharp or stabbing?
E- yeah, sharping pain.
Okay. Okay. Anything's worse in it?
What?
Anything's worse in your chest pain?
Watching this. No specific thing I noticed.
Is it going anywhere else?
No.
Okay, if I give you score 1 for minimum, 10 for max, how can you score your pain?
Maybe 4.
Mm-hmm. Okay, I'm sorry for that. Along with that, do you have any cough?
No,
Any noisy chest?
no,
Any coughing up of blood?
no,
Any awareness of your heartbeats?
no,
Any swelling in your leg?
no,
Do you feel you need to clear your throat frequently?
no,
Okay. So apart from that, do you have any high body temperature?
no, doctor.
Any weight change?
No,
Any lump or bump in your body?
no,
Anyone comment for you are become better than usual?
no.
Okay. So can I see my patient if there's any significant?
Yes.
Mm-hmm. Okay.
Uh, I will
So
send. I will
okay.
send. Doctor, just a minute. Can you do pause? Just a minute.
Okay.
Okay.
Uh,
If
I
you are
want
not
to
able
share.
to send, share it to me and I will share it here. Send
Okay,
it to me
just
WhatsApp.
okay. Mm, uh, uh, where is the group? Sorry, when I share by the name of the disease. That is why.
I didn't see it, Dr. Minas. No problem.
Yeah, I delete. uh,
Send to my private number.
yeah, I will send now. Okay. Sending دكتور خلاص.
I didn't see it. Yeah, in the chat. In the chat.
Yes, you can continue now. Dr. Sarah, you saw the picture?
Hands on. Yeah. Okay. Yes.
Okay,
Okay.
continue.
Yes. Okay. So do you have any medical background I should be aware of?
Uh, yes, I have some heart problem.
Mm-hmm. Okay.
That
Okay.
yeah. I have some heart problem regarding to my condition, and I follow with heart doctor.
Okay. Okay. So do you have any blood clot before?
No.
Mm-hmm. Any lung problem before?
Yes, as I said to you that I have many this problem from before.
Mm-hmm.
Yeah.
Okay. Okay. So could you show me your medication list, please?
Nothing specific.
Okay. I'm sorry for asking this question. Any recreation medicine?
No.
Any family history of similar condition?
Yes.
Okay. Which one in your family?
My brother.
Mm-hmm. Okay. I can see that from your pictures that you are being tall. That
Yes.
your has the similar.
Yes, doctor.
Okay. Any family history of not?
No, just this problem in many of my family.
Okay. Any family history of blood clot disease?
No.
Okay. So do you have any joint pain?
Yes, doctor.
Which joint?
Uh, Actually, all of my joint, but mainly the knee.
Mm-hmm. This pain, is it
Back pain.
increased with when you are doing activity? I mean, with movement or at rest?
Uh, occur with activity more.
Mm-hmm. Okay. Apart from that, do you have any skin rash or any skin change?
Uh, I have some, my skin looks like I have some marks in my skin.
Mm-hmm. Can I see it?
Yes, you see that skin lax and
It's
stripe.
the same. Okay. So any tight skin or shiny skin?
No,
Okay. Do you have any deformity or any back pain?
yeah, I have doctor, as you see now.
Okay. So do you have any change in water work
No,
regarding the amount, color, frequency?
no,
Okay. Do you have any headache?
no.
Any vision problem?
Yes, doctor. I have visual problem and I follow with eye doctor.
Okay. So are you aware regarding what the vision problem exactly?
Yeah, he said that I have some problem in my lens, but I
Mm-hmm.
don't know what that exactly.
Okay. So do you have any weakness anywhere in your body?
No,
Any difficulty in combing your hair or getting up from the chair?
no,
Okay. Any altered sensation in your body?
no.
Okay. I'm sorry for asking this is basic question. Yes. Are you married? Do you have any long intimate relationship?
No.
Okay. So apart from that, yes, what you are doing for living?
I am a teacher.
How much your condition impact your job and usual daily activity?
Yes, sometimes because of this joint pain and this shortness of breath, that
Mm-hmm.
interrupted my work.
I'm sorry for that. I will try to help you regarding this. Okay. So do
Mm,
you smoke?
yes.
So we advise you to stop smoking because the smoking is related to your health and it may harm your conditions more. Is that okay?
Yeah, okay, doctor.
Do you drink much alcohol?
No.
May I examine you now?
Yes.
I need the vital chart of the patient.
Uh,
Yes, there is respiratory rate, blood pressure, oxygen saturation.
yeah, oxygen saturation, pulse 82 regular, and respiratory rate 20,
Mm-hmm.
SpO2 88.
Mm-hmm.
Yes.
Okay.
Blood pressure
Okay.
normal.
Okay. So yeah, and also I need to measure the arm span and compare it with the trunk span.
Yeah, disproportionate.
Okay, so I'm going to examine the hand for arcanodactyly. The fingers, is it tall?
How you examine?
Yes, just I will check it. And also I
Yes.
will, yeah, I need to do مش ناحية بسم الله ما طارت لي. Okay, I need to do uh, hmm, معلش. Okay, this sign and some sign ولا كان شو هي. Yeah.
Yeah.
Okay.
Wrist and thumb sign, yes.
Yes, yes.
Hmm. Yeah, it's
Mm-hmm.
positive. Yeah.
Okay. Also, I would like to check for proximal myopathy.
How you will check?
Yeah, yeah. Please, yeah, do like this and resist me, please.
Yeah, normal.
Okay. And also, I'm going to examine the eye if there's any bella regarding
Yes.
the visual acuity. And also, I would like to check by the torch if there's any for the lens And the cataracts?
Mm-hmm.
Mm-hmm.
Yes.
Is any significant?
Yeah, there is blue eyes, blue sclera, upward lens dislocation.
Mm-hmm. Okay. So I'm going to check the mouse for the high arch palate.
Yes.
Okay. So I'm going to examine the chest of the patient. If there is any deformity
Mm-hmm. What
in the chest,
deformity?
like pectus excavatum or carniatum.
Mm-hmm.
Mm-hmm. I'm going to auscultate for the chest if there is any significance.
On auscultation, yeah, there is crepitations
Uh-huh. Where?
in the middle, or no,
Mm-hmm. Okay.
in the base. In the base, yeah, there is crepitation of the base in the base of one lung. Right lung will sit.
Okay. Is it change after cough or not?
No.
Mm-hmm. Okay. So the heart. I'm going to scatter the heart. Just I would like to check for the aortic rigor. Please sit for me and take a deep breath in and out and hold it.
Yes, there is diastolic murmur.
Okay, so I would like to check for peripheral sign of the aortic rigor, like the large volume pulse and the other peripheral pulses in the neck.
1 minute left.
Okay. Also, I would like to examine the back of the patient for any deformity, any tenderness, and the knee. Okay, what is your concern?
Doctor, what I have?
Yes. Actually, after I'm asking you some question, after examining you, have been trouble with this recurrent attack of shortness of breath. Is the most likely, yes, related to your condition, which you called Marfan syndrome, in which there is the disturbance or the yeah, disturbance in some important proteins, important components of the bone, and result with called cartilage, in which you called and it is familiar condition that mean Trump family. That's responsible for symptoms that you are having. Sometimes it can cause for you this air collection in your lung, and also now sorry to tell you that it might have scarring your lung. So what we are going to do now, we are going to run for you some blood tests and some scanning, and we need to trace also your hearts. We need to keep you in group of specialists, which include um, the lung doctor and the joint doctor and other specialties according to your needs. So do you have another concern?
Yes, doctor. If that disease will, as you said, that is familial. So I'm feeling worry for my baby. It will get if will get this disease.
Yes, I'm sorry for that. Yes, yes, your baby have a risk or have a risk 50% to have such condition.
Oh,
Any one
doctor.
of you. We can refer you with a genetic counsel team to discuss more regarding this.
Okay, doctor. Thank you.
Okay, the examiner questions.
Examiner. Give me summary.
Okay, so I have seen the patient, Mr. John, 45 years old, present complaint with shortness of breath since long time. It recurrence and yeah, mainly with exertional dyspnea and bronchial chest pain sometimes. And she has the features going with Marfan syndrome, yes, in the form of disproportionate arm span with trunk span. and also yes, he has yeah, yeah, okay. She has a projectile and also organodactyl, I mean, and also positive wrist and some sign. Okay. And also she has deformity. He has deformity in his chest, and he has aortic rigor. And when I'm going to auscultate the chest, he has crepitations in the right lower middle of the chest. Doesn't change after the cuff. And also he has eye change. Okay, less subluxation or subluxation upwards, and also the vision affected.
Okay, yes. So what is your diagnosis and what is differential?
Yes, diagnosis for the chest pain, for the shortness of breath, you mean, or for the as general observation?
Yeah, for after examine and take history, what is your diagnosis?
Marfan syndrome.
Yes, and what is your differential?
Yes, it could be Marfanoid body habits as the part of the main type 2, and also it could be homocystinuria for this.
Okay. And now what is your plan of management?
Danlo syndrome. What?
What?
The plan, also Ehlers-Danlos syndrome.
Okay. What is your plan of management?
Okay, the usually diagnosed as clinical, okay, but we can do genetic tests and we can do investigation to search for association and complication. Okay, like the heart, you will do ECG echo and chest X-ray, high resolution and pulmonary function test, and also check the vision. Okay,
Okay.
and genetic, as I mentioned.
Okay. And what is your management or your treatment?
The management, yes, the management, it could be non-pharmacological education counseling about his condition, an MDT group, or MDT approach, and pharmacological treat regarding now his conditions, some advice, and also involve the case doctor.
Yes. Anything else?
Also the cardiologist and other specialties.
Okay. Thank you, Dr. Sarah.
Still
Thank
one
you.
more minute. Yeah, I will ask here some questions. So again, can you repeat the differential, Dr. Sarah?
Marfan,
Okay.
homocystinuria.
Okay.
Okay. Marfanoid also as a part of main type 2 B, and
Okay.
also Ehlers-Danlos syndrome.
Okay, this is regarding the patient look. What about our case today? Chest pain in Marfan patient. What are the possible causes?
It could be pneumothorax, recurrent pneumothorax. It could be
Okay.
because I find crepitation. It could be fibrosis. I didn't sure why.
Okay.
Also, it could be at the part of aortic rigor, heart problem.
Okay.
Yes, and it could be yes, other cause of pleuritic chest pain like pericarditis, pleurisy,
Okay. What's the most
and
dangerous
pulmonary
one?
hypertension also. What?
Okay. What is the most dangerous differential?
Pulmonary embolism. Mention it. Pulmonary
What?
embolism. Yes, BE.
PE and yeah, someone is saying it.
Pneumothorax.
No.
Aortic dissection.
Yes, aortic
Oh,
dissection. Yes. Yeah, exactly. So you have to ask about the nature, the radiation to rule out aortic dissection, which is the most serious one. Okay. Fair enough. As a question, Dr. Minas, can you comment? Then I will comment.
Yeah. If you did not ask to see the patient early, you will not get the case. Am I right?
yes, yes, sure.
Yeah. Cause this shortness of breath, you did analysis well, but you did not reach the diagnosis because you did not expect the diagnosis till you see the patient. So you do well. You did well, and patient, yes, that after you see patient to confirm diagnosis, yeah, you ask that about family history of tall stature and any family history of similar condition. Uh, as you said, that this may be marphonoid feature as a part of our marphonoid habitus as a part of the MEN2P, but you did not ask in the systemic review or in the to exclude it. That you did not ask about thyroid to exclude thyroid disease. You did not ask also about الهوموسيستينوريا also at a differential to exclude that with mental or learning difficulty. You did not ask about that. And also you did not ask أيوة, as a part of MEN2P, you did not ask about pheochromocytoma. Am I right?
Okay, continue.
Yeah. Also, one of differential that Klinefelter, very tall patient. This will excluded by asking to screening for infertility. Also, you did not ask. And regarding also then examination.
Okay, I ask you regarding, do you have any long intimate relationship? You say no. That is why.
Yeah, but I think that for infertility to rule out Klinefelter.
Yes. Okay.
Okay.
Okay. And also I told you that I have heart problem. You did not ask me what exactly that from that time I will say to you this may be valvular lesion or like that. And also you did not ask about surgery. If you ask me about surgical history specifically, I will say to you that I have because of this recurrent pneumothorax I did pleurodesis for recurrent pneumothorax, did surgery before. On examination, yeah, you examine the general look and you confirm that finding of Marfan, but that in the mouse also sign that high arch palate and also neuroma, mucosal neuroma. You did not be specific for it. And in the abdomen, one of the complication, aortic aneurysm or dissecting aorta. Also, you did not examine, and also for hernia, cause this connective tissue disease, you did not examine also. I think also in the neck, as I said, that may be part of the men to be. You should do examine for thyroid. You did not did. That is all. And also in the management regarding treatment, we should if a patient have dilatation of the aortic root, we should start in beta blocker to slow down dilatation of the aortic root. And annual echo also you should mention. That is all. You reach the diagnosis early, as I said. Cause this shortness of breath not specific for disease. This is many disease can be presented.
Okay, Doctor.
So you did well, yeah.
Yeah, thank you, Dr. Minas. So is it pneumothorax?
Now this shortness of breath not pneumothorax, but maybe a complication of this restricted lung disease as complication of the condition. Restrictive lung disease, yeah, that is also in the investigation. I think that may will ask or may will from your plan to do this pulmonary function test.
Okay, so restricted due to the chest wall deformity, not related to the
Yes.
lung itself.
No, not for the disease condition itself, for the Marfan, that connective tissue disease, yes.
Yeah, it's not parenchymal disease in the lung tissue.
No, due to chest wall deformity, yes.
Okay, so it's not crackles. You will not have any crackles. You will have only limited expansion by the examination, right? Because you mentioned crackles, I think.
Yeah, and also I think that also lung fibrosis, one of the complication.
What I don't know how the mechanism it happened. Lung fibrosis complicated to what?
One of the complication of the yeah, one of complication of the Marfan. I
Okay.
think so.
Okay, let me confirm it, but I didn't hear about it before. Yes, it can develop, yes. Although it's not the most common pulmonary manifestation. Spontaneous, yeah. The other thing we mentioned, tissue inflammation caused by chest wall deformity. So the fibrosis potentially arising from tissue inflammation caused by chest wall deformities or from the abnormal elastic fibers due to the genetic mutation itself. Okay, good. Okay, it's not common, but it happens. Thank you, Dr. Minas. Okay.
Yeah, you're welcome.
Yeah. Okay. Any other comment? Kyphoscoliosis, not sclerosis. Kyphoscoliosis. So the test, pulmonary function test, what do you think the test will be, Dr. Sahara? What will be the test conclusive? Pulmonary function test with this limitation or with kyphoscoliosis. What do you think the features will be? Okay, anyone else can answer?
Yes, Dr. Basim, I'm sorry, I didn't hear you. Yeah. What is your question?
Yeah, what is the finding in the pulmonary function test
It
related
could be
to the
restrictive in this patient. Yeah, restrictive.
restrictive? Okay, so the forced expiratory volume 1 divided by forced vital capacity will be
More than 70.
more than 80. Okay, what about the DELCO, diffusion?
It could be decreased.
Okay, if we said fibrosis, it will be decreased. If we said only kyphoscoliosis, will it be decreased?
Normal.
Yes, it will be normal. Okay, that's it. Okay. Any other comment, Dr. Minas? Or any question,
Yes,
Dr.
just
Sarah?
the cause of shortness of breath in this patient, non-fibrosis.
Yeah, so there is some evidence it might be complicated in the Marfan, as kyphoscoliosis might be complicated
Okay.
by the lung fibrosis, although it's not common. So
Actually,
the
doctor,
pneumothorax more common. Sorry.
Because
sorry, this
also he is associated with the paralytic chest pain.
Yes, but it's so the differential here will be either
For no cough
as
also. That is why.
yeah as a common pneumothorax, but he had history of pleurodesis, so you cannot say, or you can say against that he doesn't have, or he has history of pleurodesis. So the differential will go more to the other, like aortic regurg or aortic dissection, or as in this case, based on the finding and examination, could be fibrosis. Okay.
Actually, doctor, this is my case in my previous exam.
Oh my God. So it was
That it was,
fibrosis.
yeah.
Oh, okay. It's okay. Thank you for sharing the experience as it's real case. So at least we learn about the fibrosis possibility with Marfan. But did they ask you to rule out the other cause of Marfan as a Marfanoid feature? Why I should go with the other, for example, homocystinuria? Now I confirm this is Marfan patient, right? So why I should ask about homocystinuria or about the meant to be? This is a case of short of breath. If they told me this patient is tall stature, try to approach the tall stature, I should do the analysis of the other differential. But if I already confirm this is Marfanoid or Marfan syndrome patient, why I should go to screen for other Marfan causes? Did you get
Because,
the feedback and the commented on this?
no, I did not get feedback. But maybe because of tall stature as a differential of tall stature. But for shortness of breath, yeah, should be that targeted only on this cause of shortness of breath in Marfan.
Yes, I will ask and screen the causes or possible cause of short of breath. But
Yeah.
why I will screen for the other causes of parphenoid feature? This is my question. Will I do that? And is it necessary to ask other causes to conclude or to rule out the marphonoid for because of, for example, homocystinuria? Although it's confirmed here that the lenses is upward, for example, dislocated. So why I should ask about the homocystinuria? Anyway, I don't know the mark. Maybe what about the mark in this case with your performance, and what do you think?
Actually, I passed the case.
Okay, with the
Yeah,
screening for
but I did
others.
not ask. No, no, I did not ask about homocystinuria or that.
Yes,
But for me, like Dr. Asar did, I analyze symptoms of shortness of breath.
yeah, this is
I'm
my point.
asking, but when I asked for surgery, said to me that he did this pleurodesis. That after that, I did not. Till that time, I did not reach the diagnosis. So I asked to see my patient. That time I saw him is Marfan.
Okay,
So I complete my history and examination.
okay, and the mark was you pass with good mark, full mark.
Uh, I I did not remember,
Okay,
but
I
I
want to
passed the
know.
test. I think
Yeah,
16
yeah,
of 20. I think 28. The case I will revise and I will.
yes, please, because it's very
Uh,
important to know, and as well as the feedback. The feedback, by the way, is very important. And this is your right. You have to call for your feedback. Why? Because based on your feedback, you will know what's your defect and which skill and which skill. Because you have to improve this skill or other skill, right? Differential or clinical communication or examination or finding. We have to know, or you have to know, and at what skill you have to improve. Okay. That's why I'm thinking it's not necessary to ask about the other causes of Marfan. However, if you screen quickly, okay, but if it will take time, I think it's wasting to the time to find the cause of Marfan. Although I find the cause, like Marfan with upward dislocation of the lens. So I shouldn't go for the other cause like the meant to be or homocystinuria. Anyway, if you have the feedback or you have the mark, just let us know. Even send me privately. But the take home message from this scenario that short of breath, it can be not only pneumothorax, PE, and aortic regurg or ischemic heart disease or aortic dissection. It can be also fibrosis because of the kyphoscoliosis, chest deformity. Okay. By the way, you have to know and to rule out the aortic dissection by the question: is the pain going to the back? Because it's important to rule out aortic dissection. It's very common to have aortic dissection as a complication to Marfan because of aortic root dilatation. And you have to mention the echo finding and the echo screening for those patients to follow up the aortic root diameter. Whenever it's increasing, the patient might be candidate for the stenting or replacement. Okay. Okay. The comment here, yeah, kyphoscoliosis restrictive. Could you please mention the different, Dr. Sarah, the different differential diagnosis again? So the differential related to the pain as a presentation, I should put a differential for the pain itself, not as a differential for Marfanoid or Marfan syndrome. What is the possible pain in Marfan? Pneumothorax, pulmonary embolism, ischemic heart disease, aortic regurg, or aortic dissection. I will not say this is maybe Ehlers-Danlos or this is meant to be A or to B or this is homocystinuria. So what is the differential? I'm not talking about the tall stature. I'm talking about a complaint, the presenting symptom. Why this patient presented with chest pain or short of breath? Why I'm talking about the tall stature differential? Okay. Okay, Dr. Sarah, the challenge is not to know the case. The challenge is to exclude other conditions that share Marfan patient's same feature like tall stature and other sign and symptom. I'm against this comment. So what the benefit if I know this is Marfan related to meant to be? What's the benefit? He is Marfan or he's having Marfanoid feature. What I will do if he's homocystinuria or unless the patient is coming to analyze and to know why I am tall stature. If he knows that I am a Marfan, what the benefit of screening? Is it Marfan related to 1, 2, 3? If he asks me why I am tall, I should screen. But if he told me I have short of breath, I should know why he's having short of breath or chest pain. This is my opinion. I don't know. You can share with me now. What do you think? Is it important to rule out the other causes of Marfan or to rule out what this patient is having? I want to confirm he's Marfan by the test, thumb test, wrist test, and the high arched palate, the lens by slit lamp, the aortic regurg finding the pulse criteria, okay, and the skin nature. But why I will go to ask about why he is Marfan? He's already Marfan. Anyway, let's share. Anyone want to comment about this point? Anyone want to say based on
I
any?
think yes, Dr. Basim. Just we need to ask some question regarding each one, homocystinuria and Marfanoid or men, because
Okay,
sometimes the examiner, yeah, you can ask regarding the differential at general.
okay,
Also,
Mhm.
I think if the question not clear, we can ask the examiner what he want exactly.
exactly,
That
yes,
the differential of the Marfan itself of the cause of shortness of breath, so we
Yes,
can answer
that's it. Right.
accordingly.
I'm asking you
yes,
regarding the time. Yeah.
yes.
What
This
about the time, Dr. Minas, in the exam? You finish
For
all the
me,
examination of Marfan's and the chest and cardiology examination.
yeah, examination. I did chest examination. I just confirmed the Marfan fastly, but then I did chest examination and cardiovascular only.
Okay.
okay. Anyone want to
The examiner
share?
asked you regarding the shortness of breath differential or Marfan itself.
Just ask me what is diagnosis and what is their differential. But
Mm.
from outside scenario, patient complain of shortness of breath, as I said to you now,
Mm.
DSAT, and also I think that give me a pH outside, like
Alkalosis.
respiratory. Yeah, alkalosis. Yeah.
BE معناه pulmonary embolism
Mm.
most likely.
Not alkalosis. I do not remember, but give me pH outside and DSA to normal blood pressure and normal
Mm.
other vitals. Mm.
Because the lung fibrosis are likely came with DSAT and acute
No,
presentation.
fibrosis will present with hypoxia. It's a matter of hypoxia rather than
Yeah.
ventilation.
Matic.
So the CO2 might be normal and the oxygen saturation will be low because of fibrosis, unless he's having limitation, very important or significant limitation of the expansion. So the patient will have ventilation issue and the CO2 will be high, not washing out. He will be limited gas
Acidosis.
exchange, CO2 AS exchange, so the CO2 will be high
Mm-hmm.
Even
because of
that
the
complaint,
limitation. Yeah.
yeah, even his complaint for many years said that recurrent, unlikely to be PE. Even
Mm-hmm.
PE with a small imply recurrent, PE with a small imply, I think no clotting issue, blood clotting issue with Marfan.
Yeah,
But the
it's with homocysteine.
pyloritic chest pain again is the pulmonary fibrosis or lung fibrosis.
So yeah, I agree with the pneumothorax as a possible differential as
Yes,
recurrence. But if not
it
recurrent,
could be yeah, pneumothorax and
yeah, as recurrent. But
PE as
if
pyloritic chest
progressive,
pain, yes, with
yeah,
shortness of breath.
if progressive, yes, I can talk about fibrosis. But if recurrent attack, so I will conclude pneumothorax
Mm.
or heart failure.
But
Yes, I
already
agree with aortic regurg, heart failure. Yes, it can be.
but from history, he exclude that there is no sign or symptoms of heart failure, like
Mm.
even that no swelling, no leg swelling, no
Yes,
orthopnea,
baby.
no paroxysmal
Mm.
nocturnal dyspnea from history and examination.
Yes, not
Mm.
heart failure in this scenario, just
But
pyloritic chest
maybe,
pain
yeah,
with injection
maybe
and
also
dyspnea.
differential shortness of breath, maybe differential, yeah, heart failure,
Mm.
cause of valvular disease.
Yes, I agree. I agree to say
Mm.
heart failure as aortic regurg manifestation. With the severe aortic
But in
regurg,
the bottom of the list, pneumothorax and pulmonary embolism should be يعني should be yeah
okay,
early
should
in the
be
differential.
okay, sure. But rather than saying also fibrosis as a common
Aortic dissection.
aortic regurg as heart failure complicating the aortic regurg itself can be there. Why not?
Yes.
Okay,
Mm.
yeah. So Dr. Riventhi commented, I agree with him. I think it's better to evaluate for short of breath rather than inquiring about Marfan features. Yes, exactly. He's already diagnosed the patient, diagnosed, yes. So the task is to focus history and examination. I agree with this. Dr. Huda asked you, Dr. Minas, when or where was this case? The Marfan, which center having Marfan? Let's know.
It's in Ajman.
Okay, good. So Ajman
Yeah.
has, yeah, Ajman as a center, they are having Marfan patient. Take care. Those for
Mm.
Ajman candidate. Okay, the pneumothorax, heart failure in any center. This case, okay, we
But
already mentioned.
pneumothorax, Dr. Basim, and I said that pneumothorax, he did blurdesis
Yeah, yeah,
already.
yeah. Yeah, he want to distract you,
Mm.
but you should put it at the right side. He will not do polyrhodosis in both sides, right? He might have pneumothorax to the other side, but again, don't put it as a first differential. Put it second differential. Okay. Yes, you can say to the examiner against that there is no pleura itself. Already the patient underwent pleurodesis. But the pneumothorax as a complication, it might be still one of the differential in any Marfan patient. He has two lungs. So if he did The Bolourdes is in the right, it might be to the left. You don't know, right? Unless he's saying to you, I did or I have done two Bolourdes in both sides. So from where the air will come? Anyway, the case for differential, I think, and I think also if you ask for the feedback, it will help you a lot, and also it will help us. But I think the time is past. You cannot ask for the feedback again. But for others, anyone, better to ask for the feedback. It's also for you, not only for anything else. It's for you. This is your evaluation. You have to know where is the defect, at what skill you have to improve. Okay? Okay. Anyone want to comment or add a question?
Yes, regarding the blood pressure, also we need to check it in the both side
Um, it's
for aortic dissection.
aortic dissection. Usually, it's coming as subclavian. Yes, you're right. Yeah, it might be starting from the aorta from the origin or the root of aorta. So yes, it might affect the all branches, not only the descending. Yes, we have to offer it. Make it as a habit to ask about the vital chart, pulse, blood pressure, temperature, and blood sugar. Do it in every case. Particularly the endocrine, you have to put the blood sugar and urine dipstick. And for the vascular cases, you have to say the blood pressure in both arms, as well as the radiofemoral or radial delay. Any
Yes.
case with vascular element involvement, please add it to your screen. I would like to do the radial or radiofemoral delay. Okay. Exactly, yes. Dr. Zohair also commented the same. How and when ask about feedback. Immediately after the result. Within 1 month, ask about it. They will send it to you within month. But after 1 month, I think even, I don't know, I'm not sure if they can provide you the feedback even after 1 month. But at least message them and they might send you the feedback. But it's very helpful for yourself to know what's the defect and to know how the examiner are thinking about how they are judging you, not only you because they are judging all, but specifically you have to know why I get this mark with this examiner. Is it examiner problem or my problem? If my problem, I should improve it. If examiner problem, we should avoid it. Okay, either by changing the center or changing the luck or preparing yourself well. Maybe the examiner is right regarding your performance. Maybe you are really you miss a lot of things and he's judging you in the good way. Okay. Any other question or comment? Dr. Sarah, Dr. Minas, anyone want to share, to comment, to ask?
Oh, thank you, Doctor.
Okay. Thank you, Dr. Minas and Dr. Sarah. Thank you for the all
Thank
attendee.
you, Dr. Welcome.
Okay. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.